All right.
Good morning, Mike, or good afternoon, or good evening, I guess, there in Abu Dhabi. How are you today?
I'm great. Um, just came off from a day of work. It's an unusual day because it's not the usual day, which is usually filled with clinic and operations. Things have changed quite a bit since the onset of the pandemic. We had it all started here in Abu Dhabi back end of February when there was a bicycle race, international bicycle race, and they had participants from all over, but two cyclists or their team members were positive for coronavirus and caused them to be locked down. And but then it became recognized that there was a number of sporadic cases. You have to remember, Abu Dhabi and Dubai are major airline hubs between Asia, Europe, and North America and
Yeah,
South America. Basically, internationally, so much air traffic goes through here. You can't finger it on just a few individuals, but rather it's just the whole system.
sure.
Um, Once that started happening, it was recognized that Abu Dhabi was not going to be immune to this worldwide process. Um, the amazing thing was from the very beginning uh, at the governmental level and also uh, at the hospital level, there had been preparations for this sort of disaster. A friend of mine who's somewhat in the know said that they had been sort of wargaming a pandemic here for over a decade now, and they were somewhat prepared for laying down social distancing and other measures. So it wasn't something that came out whole cloth. They had studied the response to SARS and what was effective and ineffective. So we saw movement on this pretty fast. With regard to our Cleveland Clinic Abu Dhabi leadership, they were able to start the planning and organizational processes very early on, including inventorying our supplies. One of the strange things about working out here in Abu Dhabi is that when they started this enterprise now 6 years ago, they over purchased some things and so there, we literally have containers full of materiel of some things and other things we have to wait to get shipped by slow boat. But one of the things that we've been blessed with has been plenty of PPE, and that's been serving us pretty well. Um, right off the bat, there was a organizational plan to create COVID-19 floors and a plan for ramped up testing. And in Abu Dhabi, the testing is centered at one hospital that takes all the specimens and turns them around in about I've seen it as fast as 6 hours in about a 24-hour turnaround period, which is reasonable for sort of a high throughput PCR test. Um, until we get individual antibody testing, that's as good as it gets. And in our experience, we've been finding like a fairly high false negative rate. They're reporting around 20%, but it is what it is. We have a tent set up outside the emergency room. So the first thing that we did was lock down the hospital to limit the number of entry points and put in thermal scanners. And so everyone is scanned and screened now on the way in for fever and COVID exposure, and are directed to our strongest point, which is the emergency room, where the patients are screened and tested and swabbed, and then either sent home for a home quarantine, or if they have symptoms or need admission, they get admitted to one of our negative pressure rooms. And that's the other strange thing about the CCAD. It's not strange. It was by design. Apparently the whole hospital basically functions as kind of like a space station. There's 100% air exchange in the hospital, meaning all the air in the hospital gets turned around through filters throughout the day in every part of the hospital, which apparently is unusual for a hospital structure. We also have over 40 negative pressure rooms on the floors, and they're I think they're in the process of converting more. We also have 3 floors of ICUs, and also PACU space and unused PACU space that is going to be converted as well.
So a lot of capacity
for overflow if needed. Yeah, a lot of capacity, and the observation so far is this. I mean, of the people who I've seen getting COVID come through, they've almost entirely manifest mild and moderate symptoms. So last week we had a leadership meeting, and there were 53 cases that came through CCAD, 18 of which were cured and sent home. And only 1 was severe and in the ICU. Then that was what last week's data, but and there's been kind of that flattened curve, slow exponential uptick in the number of cases in the hospital over the past just week. So we haven't seen the end of the story yet, but I think they have been very successful in flattening the curve. But if you think about it, what that means is the area under the curve is still going to be the same, whether it's flat or spiky.
Yeah.
And so that the peak is now delayed.
Yeah.
The peak is delayed from a tsunami occurring in a month to just a steady rise that's going to happen towards the beginning or midsummer. But that we should be well over capacity for that kind of flattening. Hopefully it won't rise tremendously.
So if I hear you correct,
yes.
If I hear you correct, you've not had a really surge, peak, or plateau. You've really just had a successful flattening or prolongation of the curve. And so you guys, as much as it's anticipated, and obviously no one can predict, but you've not had a peak where your capacity has been stretched.
Yes, and that's led to a bunch of different theories, in that the high percentage of mild and moderate cases, and I've actually seen this, and we have two patients with vascular disease primarily who were admitted with COVID positive assays, who over the period of a week converted to negative. At least they were not detectable from a nasopharyngeal sampling. I'm sure if we took to the trouble of doing a bronchoalveolar lavage, we'll find some virus, but that's not necessary. Those patients don't need their operations right away, so that they're going to be discharged. But that's been the pattern. There's been some chatter. How doctors love to gossip that maybe we are seeing a different strain of virus here, and that the emirate has been isolated early enough that we don't have a more virulent strain that may be responsible for the high mortality rates outside in Italy and New York, and that may be the case. But certainly we have yet to see a in-hospital transmission yet. Now it's early days, and so everyone's being very careful. We just got the order to wear surgical masks with patient interactions, but we've also dialed it back. So we've stopped doing elective cases for the most part. Aside from what are now judged to be critical elective cases for services that the patient would suffer problems if delayed beyond what we anticipate. And so, um, they've opened the spigot on that a little bit, but the patients also have to be COVID negative, and that's part of their pre-anesthesia testing is a COVID swab, and they have to be socially isolated and come in within 2 days of their swabbing and be negative.
So
As a
just to get
practice,
an idea,
we have yes.
just to get an idea of how you guys sit in reference to New York, when was the first case in Abu Dhabi?
It was it was back in end of February, I think. It was I have to look it up actually, but
Yeah, so it was early.
the
It was
first
earlier.
case.
It was an early case. It was kind of mirroring the Seattle experience. You guys at least started around the time of Seattle.
Yes, and the wheels started moving very rapidly. Uh, be- and this is so that we would avoid something like Wuhan happening here, which would be kind of disastrous. There are several structural reasons why preventing a massive outbreak is good in that most of the population here is expat. And the majority of the working population here is not from here, and so there are large dormitories and camps where people who are in manual labor and construction and service industries, they live very close to each other, a couple of hundred to a block, let's say, or to a building, and those would be major centers of COVID spread if that were allowed to happen. So that those locking those areas down and controlling spread was a very important thing. First off, the other thing is that this country is a very social country, and so it goes against the nature of everyone here to be socially distanced at first, but and therefore the measures were somewhat severe and firm and hard. They put some teeth into the restrictions. If you're caught out past curfew without a reason, for example, being a doctor, there are fines and even jail time. So that's been very helpful in getting people to socially distance, and so it's worked.
That said, there is community spread, correct?
Yes.
That said, there is community spread.
Absolutely. Well, absolutely, because we're seeing the uptick in the numbers, and that's it's kind of unavoidable. It's no social distancing strategy is going to be perfect. People still have to go grocery shopping. People still have to tend to older relatives or kids, and it, it, it's a slow spread though, and that's the idea. And also the idea is if we're all going to get it, it would be better to get a mild or moderate course than a severe one. And thank God it's been mostly mild to moderate cases we've seen so far.
Yeah, absolutely. And so it sounds like the provider group has not been affected dramatically. We've had some reports here, and it's reported out of New York and out of Seattle that some providers, and it's postulated perhaps with high viral loads, are falling quite ill after being exposed in a hospital setting.
We've had a trickle. So for example, my partner is out with a temperature, a fever, and some flu-like symptoms, but has been COVID assay negative, and he may just have the flu. And we've had a handful of caregivers go COVID positive, and they are hospitalized. But again, it's a short hospitalization once they get 2 serial negative tests, they're sent home with home quarantine for 2 weeks, at the end of which they also get a repeat test, and if they're negative, they're cleared to go back to work. And so there is a pathway for people to return to work after going COVID positive, and we're beginning to see people who have that, and assuming you get through that, you may have some immunity. That would be the bonus of it.
Absolutely. So in terms of your vascular surgery practice, how have you guys categorized cases in terms of prioritizing which cases are elective and which cases should be done?
Early on, there was that schema put out by I think Thomas Forbes, the VASCON 5 through 1, but basically it's a rubric which lets you decide how to outlay your resources. And the bottom line is, as a whole enterprise, we chose to cut off elective cases, and then create categories of urgent and emergent cases that we would do. And so they fell under the VASCON 4 rubric of aneurysms greater than 5.5, dissections, and that was early on. And then the ACS SVS guidelines came out, and we basically folded those into our plan and rubric. What's our challenge here is that there isn't a pool of retired vascular surgeons and large groups of other vascular surgeons nearby to rely on if we got COVID. And so there's only 2 of us, and so I've also done as the chief of vascular surgery here is go through the general surgery department and found people with with vascular certification or training, like sort of a coalition of the willing who could manage vascular emergencies, bleeding, and whatnot, which and also in the endovascular certified staff gone over different scenarios that they would manage vascular emergencies endovascularly in the absence of a vascular surgeon, or if a vascular surgeon was tied up. That's allowed us to create resources for basically teamwork, because and that's been one of the nice side effects. So, for example, last week we had a patient with acute mesenteric ischemia. The SMA was completely packed with thrombus. I was able to use a device that the neuroradiologists usually use, and got them gave them feedback on that case, and was able to get them more or less willing to help out if any other kinds of clot needed to be removed in other parts of the body, and so that's been a very important part of the whole scheme. We've also each of us been given secondary roles for redeployment if the need came. So both myself and Hussam Yunus, my partner, are going to be deployed to the ICUs, and all the people who are ICU deployable are taking refresher courses on vent management, ICU protocols and routines, and order sets, and so that's also in the works. And both Hussam and I are general surgery boarded, and so we've made our services available in case that need arises. And so we're a little bit different from. I think we're in some ways a little bit different because we're much more of a closed environment, sort of like an Antarctic camp or a space colony, more than anything else. And so we really have to use the resources and skill sets that we have in place, rather than be able to get on the phone and get someone to come over here and help out. that's just basically impossible to do under these circumstances right now.
Yeah, well, it's a team of teams, as you described, a coalition of the willing, and
Yes.
everyone has to pitch in, and we're all in it together. So all of those platitudes count here, and at the very least, you guys are with one of your vascular surgery colleagues having fallen ill. You guys are on a team kind of alternating scale, and you have one person with immunity at this point.
Yeah. Yeah. It's actually um, uh, that's the one thing that com- I'm in touch with him several times a day just make sure things are good, and things are fine. He's on the mend. That's been the case again here. Is that most of the cases have been mild, and as soon as they're back in action, he will be immune, hopefully, and so um, so we're going to be working at this for a while. So the models were presented. Basically the mathematical models were presented at this most recent meeting. So we also have huddles. I know you guys have them at the main campus as well, but the huddles are basically hospital-wide meetings and they're now done electronically, but we go over the leadership presents the data, and then we can reflect and give feedback in real time. And this happens several times at the small unit level and at the institute or departmental level and on up, several times a day or sometimes during the week. The mathematical models show that the peak here, if the curve isn't flattened, will happen in May. If it's completely flattened, it'll happen in October, and the most likely peak is going to happen sometime midsummer. And that means we're in it for a long slog.
Yeah.
I don't know what that means for the rest of the world, but this may be the new normal for a while, and so we are on this war footing.
Yeah, it may be the new normal. It'd be interesting, and it will be interesting. Only time will tell if it kind of plays out that the UV exposure and the different climate that you experience there in Abu Dhabi is playing a role into what appears to be a relatively, knock on wood, good control that you guys have of this process, because it seems like you guys are handling it
Yeah.
well. And as you described earlier, maybe it is potentially a different strain, or maybe it's the environment, but there's something in play. But I'm glad it's working out well.
Yeah, that definitely probably has some play into this around the GCC, around the Middle East. We've they've been able to affect distancing far more effectively than in the U.S. I mean, there are certain things that a monarchy has an advantage over a republic, in that you will be able to get people to work together really fast, and and other countries around the region have also put in various degrees of draconian social distancing, and they have to, because most of the world does not have infinite resources with regard to healthcare, and even the U.S., which has the advantage of high-end healthcare, doesn't we were always working on a just-in-time supply chain. I mean, you're not going to have lots of something, but the stuff showed up very rapidly, sort of like your Amazon delivery showing up the next day, you see, we're seeing that system stressed tremendously. Here, because we're so distant from everyone, we've had to stock up normally to be able to whether dips or over usages, and so the supply chain has to predict and then keep certain things months ahead of stock, and so that suits this area pretty well for this kind of situation. So I think there are many things, but again, it's a terrible thing that's happening, and I think while we fight this on the medical side, there's a tremendous economic price that's being paid out there. People who rely on their paycheck week to week are going hungry around the world, and so I think part of the process also involves thinking about your neighbors and making sure that they're safe and secure. And because it's going to be a long slog, I think more communitarian attitudes will come into play. That you think of yourself not as the people inside your walls, but the people in your neighborhood and in your towns and in your region and state. That's going to be very important for all of us to get through this together. And so it's changing the way people think, I think, all the way around. And the fact that we've had to change the way we practice and so quickly, so sharply, and also be able to be flexible enough to pivot very rapidly is, if that's the new normal, it actually may be a good new normal that we're flexing our nimble joints, our nimble muscles, the ability to use data in real time and to change a large organization. I mean, we're a pretty big place. There's over I think 500 doctors, but a couple of thousand caregivers here in total. To be able to make changes on a day-to-day basis is a tremendous thing, and so to be able to get the message out to the entire enterprise, these are important lessons, and I hope we are able to keep it because in fact we worked together. We're working together and gelling together as a team under these circumstances far faster and far more rapidly. I'll give you an example. The plan to roll out virtual visits and teleconferencing was a months to maybe a year-long plan that was being rolled out along with many other projects, including Cancer Center, including new ORs and new patient floors. That came out and rolled out within a week. They got teams of programmers and IT people working on that over day and night, and now we have the teleconferencing baked into our IT system, where basically on our EMR you press the button and the patients have an app. They get to see us on their patient portal app. That happened in literally a week, and that's amazing. And so I think that as bad as this experience is, there are some positives to take away from it as an organization.
Absolutely.
And and for myself personally.
Absolutely. Mike, I appreciate you taking the time to share with us what's going on in Abu Dhabi Cleveland Clinic. I'm glad that you're well, you and your family are doing well, and the folks around you. So hang in there. I think the lessons and some of the ideas that you've shared with us today are valuable in helping us as we enter our surge or peak or plateau, or however our pandemic curve pans out. So thanks again. Be safe and be well.
All right, you take care. Thank you very much.